I just want to introduce myself. I'm Dr. Andrew Belis. I'm one of the partners here at the Orthopedic Center of Florida. I also run a fellowship, and Dr. Stewart is next to me, and he will be working with me to present to you on Equinus today. A little bit about our practice. We're a multi-specialty orthopedic group, and we are based in Fort Myers, Florida. We have plenty of opportunities for our fellow to scrub in with ourselves and our other attendings, as well as local area orthopedics and podiatry, surgical podiatrists in the area as well. So we try to make this a really well-rounded program. Very excited to have Josh on board. He's doing great so far, and it's been a wonderful experience. I do want to thank all of the prior sponsors for this webinar series, as well as for the Fellowship Society. As Adam said earlier, this is a kind of a love of ours that we wanted to give back to our colleagues and our younger members to empower them to have educational opportunities and have them, extend their learning opportunities as well, and actually become leaders in our profession. So this just kind of helps us give back, and it's really a love of mine as well. In regards to, I'd just like to give a shout out to Orlando Production for helping us tonight. That they're making me look good today, as well as Dr. Stewart. And thank you guys for being here, and Doug Loran and Mike as well. So today we're going to be speaking about the Equinus and decision making, and I'm going to let Dr. Stewart kind of take the reins with this. But as you listen to tonight's webinar, just kind of think about when you see patients in the office, and what is your mindset? What are you thinking about? Do you think about what type of procedures you want to do, or how you want to manage these patients? And it's a very important topic. It's a simple topic, but it's kind of important because the decision making, as we do for all surgeries, is really the key when you're wanting to have a successful outcome with your patients. So we're going to go through some of the factors that we look at when we do decision-making processes here. So I'm going to let Dr. Stewart. Dr. Stewart, welcome and thank you.
Thank you very much. So as Dr. Belis mentioned, I will be talking about Equinus for a bit. Briefly, what Equinus is and why do we care about it, why people think it's the root of all evil, and what can we do about it. As with any deformity, surgery, pathology, the key to understanding it is understanding the anatomy. I know we all understand the anatomy, but the biggest point here is that the gastroc does cross the knee joint, and the medial head accounts for about 70% of the strength. So while there's no universally agreed upon definition of Equinus, it is at its most basic passive, or a limited passive ankle dorsiflexion under 90 degrees. So if you can't get the foot to 90 degrees on the leg, you have Equinus. Typical ranges that have been agreed upon within literature are with the knee extended between 3 and 15 degrees is normal, and then with the knee bent 10 to 20 degrees is considered normal. So the maximum dorsiflexion that's required in the gait cycle is just before heel off. It's with the leg extended. If you have Equinus in this part of gait, it can have many impacts. It can cause you to have premature foot loading, reduce propulsion, reduce stride length, reduce velocity of your gait, and early toe off. So why does this all matter? Well, we all know, but some research shows that up to 97% of examined patients with pathology in a foot and ankle clinic had some sort of reduced ankle joint dorsiflexion. And then one of the most common pathologies we see, plantar fasciitis, about 83% of those patients have Equinus deformity or contracture. So is it the root of all evil? This is by no means an all-inclusive list, but the compensation for Equinus is far-reaching. So if you're not evaluating for Equinus, as Dr. Belis said, it's simple, but it's very important. If you're not evaluating for this, you're not doing a complete exam, and you are doing a disservice to the patient. You can have the forefoot pathology that occurs when the STJ pronates and it unlocks the mid-tarsal joint. You have the more proximal. So every patient, every exam should include an exam for Equinus. There are a few different types of Equinus, muscular and osseous. The muscular can be broken down into spastic and non-spastic. and gastrocnemius versus a gastroc-soleus equinus. And then the osseous type is either from a tibio-talar exostosis, syndesmotic, or pseudo-equinus. So as I said, it can be spastic musculature, usually due to an upper motor neuron lesion, like cerebral palsy, which was the first spasticity, the first cause of equinus that is noted in literature. You will see hypertonicity, hyperreflexivity, and clonus in these patients. The posterior crural muscles will overpower the anterior muscles, causing that toe walking. And then the non-spastic musculature, soft tissue responds to the stresses placed on them. So if patients are in a cast for a prolonged period of time, if they're wearing heels, any reason that they would have a shortened posterior muscle group, that soft tissue, that tendon will respond to that by shortening. So you can acquire it as well. So osseous equinus can be due to an anterior tibio-talar exostosis. On your physical exam, if you note an abrupt or a hard stop when testing for equinus, this should be at the top of your mind. If you believe this and your physical exam leads you to this thought, you can do a stress dorsiflexion x-ray, the charger view where the patient's foot is planted. You bend the knee and it will passively dorsiflex the ankle, and you will see jamming at that end range. A key here is even if they do have equinus and it's osseous equinus, they still may need a gastroc or a strayer. There could be accommodative changes to the musculature as well. Syndesmotic equinus can also occur. And pseudoequinus, this is a tricky one for some people. This is a forefoot equinus, so you're looking at the forefoot to the rear foot rather than the rear foot to the leg. So it's not at the ankle joint, but it can be deceptive and it can look like an ankle equinus. It can produce a false positive and lead you to inappropriate procedures. These procedures are usually osseous and done in the foot. So in a cavus foot, would you correct equinus? What are your thoughts?
Well, I think the way I look at this is, obviously we all know that a tight ankle, tight calf muscle can be one of the root causes for flat feet, with the pronatory effects. I think that too often we see people with cavus feet type, and I find that with cavus feet, it's very, very, very rare to actually have a tight calf muscle or even equinus, and it's usually a pseudo-equinus or an anterior equinus. So I think the rule of thumb is usually if you have a cavus foot, you don't have to consider lengthening that, but it's not the absolute rule.
So how do we test for equinus and the types? While there are no agreed upon standard accepted ways to measure the ankle joint range of motion, the silver skull test has become a mainstay in this exam. However, inter-observer reliability is inconsistent, so it's important that if you are doing the exam, you do it the same way every time so that at least your exams will match up and your experience will allow you to choose the right procedure. So I know that I've seen Dr. Belis do this a handful of times if he wants to describe the same way over and over.
So this is, my staff hates me for this because I'm a stickler for these measurements. But basically, I do it the similar way where you supinate the foot and then dorsiflex the ankle with the knee straight. And I look at as in that picture there, you can see the back of the calcaneus where the plantar skin meets the lateral skin. And I only look at the lateral calcaneus posteriorly. I think it's too often easy to get confused with the lateral aspect of the fifth metatarsal. So that's a little bit of a stickler for me. The other thing with a more obese patient, it's difficult to see these, but that you can also write on their skin or draw on their skin, and that helps. The other thing I'll mention is that I don't take a goniometer for every single person. I think that's hard to do in a very busy clinic. But after doing this over and over and over again, if you're doing every patient every time, I usually kind of estimate, different thirds. So I go by 5. So 0 degrees, 5 degrees, 10 degrees, 15 degrees. And, it takes a little bit of effort, but you can estimate this if you really need to. If you're doing some studies, obviously measurements are important. But I actually measure these from visit to visit. I'll actually have my staff document these. And these are good things to be watchful for at each visit that the patient comes back, especially if you're doing some conservative care or night splinting. I think having them see the progress really helps to get them on board with not just doing these range of motion or trying to look for that by pain relief, but actually by using measurements that are validated, that you can kind of show, hey, this is what the improvement we're making.
Yeah. So yes, this has become a mainstay in the evaluation. If the deformity corrects with the knee bent, it is a gastroc Aquinas. But while it is a mainstay, is it clinically significant? There have been questions in the literature because you require your greatest amount of Aquinas with your knee extended. So is there a point to testing it bent when it's non-spastic? The question was raised if gastroc soleus Aquinas or gastroc Aquinas has a clinical significance with the plantar pressures. So this study performed by Aronow actually evaluated this. The key takeaway from this slide is that you can obtain similar clinical benefits with less morbidity and have the same outcome. So if you do a gastroc or a gastroc soleus, so a TAL or a Strayer, they reduce the amount of plantar pressure about equally. So if you have a patient with a plantar wound, the first thought is, hey, we should do a TAL. Well, if the patient's not a great candidate, if you think they need to walk, a Strayer may be a good option, and it may have the same benefits. But because we need to choose procedures, this does guide our way. So choosing the appropriate procedure is not just based on the silver skull. That's not just, is it a gastroc Aquinas? Is it a gastroc soleus Aquinas? Is it spastic? Is it osseous? There's a whole host of reasons. You have to take more of a holistic approach to it. You do look at the deformity, look at the age. If you're doing concomitant procedures, you need to take that into consideration. So there's a few different considerations, not just the silver skulled. So the ideal procedure, obviously you want to eliminate the contracture, expose the patient to minimal risks. You want it to be good looking and conducive to any other procedures you are doing. These procedures have been stratified in literature into different zones, 1 through 5, 1 through 3. I will be chatting about 1 through 3 for the most part, 1 being the more proximal, down to 3 the more distal. The big point here is that the more proximal procedures were more stable. They didn't lengthen much after the release. However, you didn't get as much of correction. We'll go through that a bit. So before those, a more proximal release, this silver skulled, where it's really mostly indicated for fixed knee flexion. It's the only one that's actually going to address the fixed knee flexion. That's your release of the musculature at the head of the gastroc. And then Baruch in 06 modified this thought and did just the medial gastric recession and figured that it was more stable than both. We chatted about it is a very stable procedure with less correction, but there is a risk to adjacent procedures, so be careful of that. So after incising the fascia, you will see the gastroc heads, and in the top picture, if you look in the direct center, you can see the sural nerve and the small saphenous vein. And then on the right side, you're looking at the perineal nerve. The bottom is the Baruch, and then once you make your incision, you can be staring at that tibial nerve. So sometimes the risks may outweigh the benefits with this procedure. So moving down the leg further distally, we're looking at zone 1. In this article, it was described as the Baumann and the Strayer. These are going to be more selective. You can decide if you want to do the soleus or the gastroc aponeurosis. So the Baumann, that's intramuscular. It's in a safe zone. Your sural nerve is not exposed most of the time. It's usually more superficial than this. And you can tailor these cuts to the correction you want. So something that Dr. Belis kind of harps on and taught me is just, angling your cut. You can make 3, and I think the research, we'll go to the research in a second, but it is tailorable. So if you're not getting enough correction with one cut, a great way of getting more correction is a second incision through that gastroc aponeurosis. And Dr. Belis wants to chat about his technique. It is something that I've picked up and something that I will do in my future.
Yeah, so I think the hardest part is visualization in between these two muscle bellies. They tend to want to push inside your incision, as seen in that picture here. So this is basically one of the devices I use. It's just basically a small anoscope. And the nurses always chuckle when you pull this out, and they have all these jokes about this. But it's actually one of my favorite things. You can also use a vaginal scope or some other type of retraction. If you get into a pinch, you can also use large Army navies. But the key is you need to be able to visualize the fascia on both the soleus and the gastroc, or at least at very least gastroc. And then if you see on that picture, if you you can see that basically when it opens it up enough that you can make an incision on either side of it at least 1 centimeter apart. So when you make this, you're not going right directly middle. You want to consider going off center, whether it's proximal or distal. And when you release it, and then you recheck if there's still some tightness there, you can go 1 centimeter away from that. And you can even turn this even further and get another centimeter in either direction, depending on where you go. Also, the placement for this, everybody is a little bit uncertain of placement. My technique is I like to find the inferior margin of the gastroc muscle belly. You can see in that picture there's a line there. And then I I visualize about halfway through about halfway proximal to the top portion of the gastroc muscle, and then divide that into thirds or into a half again, and that's where your incision is. So really the size of your incision is based upon the size of your retractor and what you can visualize adequately. That's just my little pearl for this very important procedure that we do quite a bit of.
Yeah, the hardest part is getting a rectal speculum into a room full of podiatrists. And then it's often thought that this is a more time-consuming procedure, but your average tourniquet time is like, what?
14 minutes. Yeah, we've done it as quick as 12 minutes, and I think if you know your tissue, and that's skin to skin. One other thing I quickly want to mention about that incision approach, you can actually close these with monocryl and get a really nice subcuticular closure. You can also use nylon, especially in heavier patients who you think there's a little bit more tension on the incision. I really don't see a lot of dehiscence with these incisions, so for me, they do well and very, very little pain. One other little trick just for this particular procedure, because we do a lot of it, is injecting the muscle where you're cutting with a little bit of lidocaine or marcaine with epinephrine. It helps keep the bleeding at bay, and also it kind of really helps with the post-op pain. Another little trick is you just want to be careful how far laterally you go. Remember, on the other side of that could be the sural nerve, or if you go lateral enough. But usually you're avoiding that. So I think you're in good shape here with this procedure. So
perfect. So as I said, it is typically thought that the more proximal you are, the lesser correction. However, you can get up to 14 degrees if you're making multiple cuts in this aponeurosis. Some people will make another cut in the soleus to gain more length. However, that's been shown to have nominal improvement, so not always necessary. Making multiple cuts in the gastroc aponeurosis is actually more beneficial. So this one, Firth, who wrote this article with the 3 zones, will consider this selective, so you can opt for just the gastroc or the soleus and the gastroc, and stable, so you're not going to lengthen much afterward. Typically, it's indicated for gastroc equinus, but it can also be done for gastroc soleus equinus, and for spastic equinus, typically a hemiplegic spastic equinus. It's excellent for pediatrics. There's research that was shown that 45% of muscle growth is at the musculotendinous junction, so this will avoid that. It's also been shown that in patients with cerebral palsy, the muscle only grows about 55% of the time, or the 55% of the rate of the bone. So if you are doing a muscular lengthening, that will be beneficial for them. It's excellent for athletes because you don't lose much strength and they can walk immediately. In terms of complications, there are fewer sural neuralgias than other procedures. Moderate procedure time, but as I said, or as Dr. Belis said, we can make it go pretty quickly once you're comfortable and once you do them quite often. The saphenous vein can be in the way of your incision if you're medial, and in theory, less final correction, but anecdotally, I haven't seen that issue. In zone 1, in first article, the strayers discussed, however, it's also been discussed as in a junction between zone 1 and 2. So that's about 2 centimeters distal to the muscle belly. The incision is made just through the gastroc aponeurosis. One concern with this is that sometimes those aponeuroses are combined and you will hit the soleus as well. So again, this is for gastrocnemius equinus. You're only making an incision through the gastric aponeurosis. It's a great procedure because it's quick. So if you're doing other procedures where the patient needs to be supine, like you're doing a flat foot reconstruction, this is a nice quick procedure to lengthen that posterior musculature. It does allow for early weight bearing, and because it's in the more proximal zones, it's still stable. One of the disadvantages is that it's a longer procedure and can be slightly more complex. So if you're looking for a quick procedure, some people will just opt, or not just, but some people will opt for a TAL. The scarring is more prominent. People get skin puckering, and sural neuropraxia is a more common concern with this one. These patients do get short-term weakness as well, but as long as they're aware of it, they're usually okay. It does go away.
Just one more thing. I do think that sometimes if you're doing these in a younger patient, especially women, you have to let them know that there's a possibility that they can have muscle atrophy in the calf that can take a very long time to get better. Sometimes I have seen a rare case where just even a year later, the size of the calf is significantly different. I've had one, maybe two ever out of the hundreds and hundreds that I've done of these actually have muscle retraction approximately. That was very much unexpected, but the technique was the same. But so just be aware that this is not a completely benign procedure, and if you've done enough, you may see some of these types of situations. You just have to be aware that is a possibility and inform your patients, especially your younger, more athletic and more cosmetic patients. So something to be aware of.
So compared to the Baumann, you can get a bit more length, but it's pretty similar. You get between 1.4 and 1.7 centimeters of extra length. Again, one of the benefits is immediate weight bearing postoperatively. They can retract up, so people often have them continue stretching postoperatively. I guess if you do the stray as it was described and suture it where you want it to be, it wouldn't, but that sounds like a lot of effort. In a similar zone is the endoscopic gastric recession. You're still cutting only the gastric aponeurosis. So if you're concerned with cosmesis, this will leave a nicer, smaller scar. It's less traumatic. There's lower risk of hematoma. And you will have direct visualization of that aponeurosis. So as you're cutting, you can see if you are cutting nerves, so you can avoid those. This is a good procedure in neuropathic patients that you're concerned with healing. And this was studied in children with spastic Aquinas, and they averaged about 15 degrees of an increase, and they all had good long-term outcomes. Some issues with this procedure: where you are operating has to have the equipment, it has to have the scope, and it can be tedious if people don't know how to use it or hook it up. It can be a lengthy procedure if you are not familiar with the intervals and you're not familiar with your anatomy. It can be tough to find that interval through a smaller incision. The sural nerve, again, that is the biggest concern with this, and it was more significant than the Baumann and the Strayer, but nominally, I don't think it was significant. And one big issue with this is that you do need to use a tourniquet. So if you don't, your field will be obstructed with blood. So if it's a patient that has had a bypass or that can't tolerate a tourniquet, this is not a great procedure option for them. A study in JFAS showed that this is overall a more benign procedure in terms of complications. So the open procedures had a complication rate of about 20%, while the endoscopic had only 2.5%. When you are doing your endoscopic gastrocs, this is what you'd want to see. On the left, you're looking at a fully intact gastric aponeurosis and those fibers. After you make your incision, you see it split, and then when you dorsiflex the leg, or dorsiflex the foot on the leg, you should see a complete gapping of that fascia. If you don't see a complete gapping, you should go back. It can take multiple swipes and make sure you cut the full aponeurosis. Further distally than that, we have zone 2. This is the Vulpius and the Baker procedure. These are non-selective. You are cutting through both the gastroc and the soleus. It is a relatively stable procedure, though, so if you want something that's not going to move much after, but you do want a correction of both the gastroc and the soleus simultaneously, these are excellent procedures. They've also been discussed with cutting the midline raphe of the soleus, so if you're not getting the correction that you want, this can add additional. So you get about 2 centimeters of extra length with about a 9-degree improvement in dorsiflexion. Indications for this, again, it was originally described, like most of these procedures, for spastic Aquinas, but it will be a gastrocsoleus Aquinas. One of the pearls that Dr. Belis has mentioned to me is that you want to make sure that you're distal enough that you're away from the striatum, but you want to make sure you're proximal enough that you're not on the Achilles tendon. You want to make sure that you're right in that zone where you still have soleal fibers attached. This is an open, prone procedure, so it can be a tough one for people to tolerate. The sural nerve does cross 9.8 centimeters proximal to the insertion of the Achilles on the calc, so this is kind of right where you're looking, so that will be in your way and something you'll have to look out for. Because it's non-selective and cuts the soleus, you lose a lot of muscle strength. It's been shown that 1 centimeter of lengthening causes 30% muscle loss, and 2 centimeters of lengthening can cause up to 85% muscle loss. And continuing our way down the leg, zone 3 are your next most distal procedures. These, again, are non-selective because they're in the Achilles tendon, and they're relatively unstable. So they can lengthen if there's weight bearing. This is indicated for strictly gastrocsoleus Aquinas. It's been shown that with 10 kilograms of force, you can get up to 3 centimeters of lengthening, so it is a very powerful procedure. As I said, it can continue to lengthen, and I've seen rupture rates up to about 10%, so patient selection is important for these. Wordy slide, but the basic indications are unhealthy patients, so patients with peripheral vascular disease that you don't think can heal incisions. If you want it to be a quick procedure, this is a great one. For a severe fixed deformity, this is a good one. It gets a lot of length very quickly. It also has a benefit in offloading forefoot ulcers. It's great in Charcot, where you don't want to open, and it's a relatively quick and easy procedure. Big contraindication to this is the weight-bearing requirement. So if a patient has to be weight-bearing after, this is a bad procedure for them. It has a high likelihood of lengthening and causing weakness. When I was talking with Dr. Belis about these, he told me he thinks I hate TALs. I don't, they just scare me. So the big issues with these are rupture, and if you over-lengthen, you can get a calcaneal gait. It's much easier to treat a patient with a little bit less dorsiflexion than with a calcaneal gait. Other options with the Achilles tendon is a full tenotomy. I've seen this done with Charcot often. It was originally described for clubfoot, but it's also done with patients with severe cerebral palsy. So if the goal isn't weight-bearing, but it's just to adapt to orthoses, shoes, or a wheelchair, this can be a quick and easy way to get that patient to dorsiflex. Again, contraindications for work on the Achilles tendon is ambulatory patients. And then the Z lengthening is a nice procedure because you have full control over the lengthening. So you make your cuts and you can slide it and suture it in place wherever you want it. Originally, this was described for neglected clubfoot, but it has many benefits. I've seen it done with a lot of pediatrics where you want to make that perfect. And the last muscular procedure is the advancement of the full Achilles tendon, anterior and dorsal on the calcaneus. It effectively shortens the lever arm of the Achilles, and it will weaken it. It weakens it by about 50% at the ankle. But this one has the benefit of maintenance of the long flexors, so you maintain a lot of your toe-off strength. It's a good one for patients who you want to keep walking and keep their strength. There's a relatively high recurrence rate, and patients, it was originally described with a button on the plantar aspect of the foot, which patients couldn't always tolerate. So it's been modified where now people will use intracalcaneal anchors, or they'll do a more medial to lateral rather than dorsal to plantar approach.
Josh, may I say that another problem with this procedure is that you now have nothing tenting the skin in the back of the Achilles area, so it's advanced forward. Now your calcaneus is actually very prominent. And so I have actually seen, we've done one of these, and they had a little bit more of an irritation back there with shoe gear. And so you have to just be careful that when you take that and you move it forward, there's nothing stopping the calcaneus from being as prominent, the superior part of the calcaneus from being as prominent. So just be aware of that could be a potential possibility, especially in like a little bit more neuropathy patient or something like that.
Absolutely. So Again, a quarter of these have recurrence. One of the ways people have opted to combat this is rerouting this deep to the FHL, which is, again, going to pull that Achilles further anterior, and you're going to expose the calcaneus a bit more. And we can't forget about the procedures for Osteous Aquinas. So this was a patient of ours. He initially had a fracture of his talus, and then it healed with this exostosis. Dorsally, he also had a pretty large exostosis of his navicular. We opted for an arthroscopic exostectomy, and then ultimately couldn't get as much as we needed because it was going pretty far to the navicular as well. So we opened it, but he couldn't walk before. He was in a boot. He was limping, in tears, and excellent range of motion now. So if it's an Osteous Aquinas, make sure you're taking down that full exostosis. Another big pearl that I've picked up from Dr. Belis is that impingement of the ankle is the worst thing you can do in the world. So every procedure we do, we take out any impingement, any joint, we make sure there's no soft tissue, there's no bone. So this, you have to be very thorough, because if you leave something, it's still going to hurt. Yeah. And then there's adjunctive procedures. I think Dr. Belis wanted to chat about the posterior capsular release.
Oh, I mean, I think basically, there is a posterior capsular release you can do arthroscopically. You can do the open option as well, especially if you're doing an Achilles, open Achilles lengthening, or Z, if you're doing any kind of Achilles repair, or if you need a significant amount of release, or if the patient's been in that position for an extended period of time. So I think don't forget about that posterior capsular release in these particular situations.
So we covered a handful of procedures. Releasing the muscle, neurectomies. You can do the intramuscular, the gastroc soleus, but still have to evaluate the patient as a whole.
Can I mention one more thing, Doc?
Absolutely.
So one of the things we kind of talked briefly about earlier was the sural nerve, and that is a potential risk. And having a lot of patients who have had some occasional sural nerve pain, it can be a very annoying issue and a very concerning problem. And earlier on in my career, I used to think, well, maybe we bagged it when they had some sural nerve pain. But I think what's happening with these soft tissue releases is that you're getting the stretching or neuralgia of the sural nerve when you get a significant amount of increase of range of motion of that gastrocnemius muscle. So we knew we weren't hitting it, and yet they were still having these symptoms. And I think a big part of what you have to warn patients about and talk to them is about the possibility for a neuritis to develop, and if it's significant, there are some treatments for that. I've actually had to do some sural nerve blocks for some of these patients where we've, even just lidocaine can calm it down and treat it. For the TAL, you don't quite get that, especially the design of the incisions. They're minimal incision. They stay far away from the sural nerve. And I think the nerve in that area is a little more flexible, and whereas more proximally, there's a little less room to move. And when you do stretch the muscle, the actual sural nerve does penetrate through the muscle there, so it may be pulling on that. And so it's just something to be aware of. Now, the good news is that studies show that these will get better. About, over 99% of these get better after about a year. But it is something to be mentioned to patients, because, you could do everything perfect in the world and all these ancillary procedures, and they have that sural neuritis in the lateral side of their foot and ankle, and that's just the annoying part for them. So, and I've had a couple of lingering ones that were just troublesome. So just mention that to your patients, and I think that's a really important fact to keep an eye out for.
All right. So pediatrics can be an especially tough group of patients to treat. They're going to come in toe walking. They can have CMT, cerebral palsy, most upper motor neuron lesions can cause this. And then patients with flat foot, muscular dystrophy, all these patients with pediatric pathology should be worked up for an Equinus deformity, which can be tough to evaluate on X-ray because the ossification of the bones hasn't been completed. And if you don't see it peds often, you can misinterpret a normal exam for either excessive or not enough range of motion. So at age 3, you should have a normal range of motion of up to 20 degrees. It diminishes to 10 degrees by age 15 as that person is walking. Obviously, with pediatrics, surgery is not what we want to jump to, or any patient at that. So PT, strapping, orthoses, intramuscular injections, and casting can have excellent long-term results if caught early enough.
May I say one thing about this slide? I think it's important to realize that, in a normal peds patient, you can get that up to 20 degrees range of motion. That's significantly higher than an adult, and they are usually more flexible. The problem is if you see a toe walker, if you see a really tight Achilles tendon or a tight calf muscle in a pediatric, you have to take it a little more seriously, because the compensation symptoms or compensation effect that occurs there is pretty severe. They get severe flat foot, as I'm sure you'll talk about, and they get, pronatory forces. And a lot of times, when pediatricians see these patients, they say, oh, you'll just walk out of it, or you'll just grow out of it and you'll be fine. And a lot of times it's not really the right advice, because, what happens is that their weight increases after a certain age, and then they just collapse. They don't all of a sudden fix their tightness. It kind of collapses. So it's something to educate your pediatricians about, that, hey, this is something that should be looked at. You see a toe walker, they do need to get in. Now, you can protect them. You don't have to jump to surgery, but, that's where the orthotics actually play a role, is it resists that pronatory force that the Achilles is putting through it. And actually, they do respond very well to conservative stretching if their parents and them are working hard to work on that. So it's just something to be aware of.
Beautifully said. Most of the points I was going to make, so we'll briefly touch on this slide.
I was excited for you.
I'm excited for you. So all of that talk about procedures, but we still don't have an ideal procedure. Again, there's a whole host of factors that go into this. So you do have to evaluate the deformity, and then evaluate the patient as a whole, what their long-term outcomes are, what their short-term outcomes are, and what their comorbidities are. So if a 9-year-old patient presented with a spastic gastroc soleus equinus, procedure of choice could be anything from the intramuscular Baumann to the more distal TAL. Initially, my thought would have been spastic gastroc soleus TAL. But a lot of the newer research shows that you don't want weakening with those spastic cerebral palsy patients. So the Baumann has actually had excellent long-term results. Let's skip to that slide. These zone 2 or 3, or zone 1 procedures are more stable, whereas these zone 3 procedures are associated with a calcaneal gait. So it does have good outcomes. However, the most recent things that I've read opt for a single event, multi-level gait assessment and fixation. So these patients often are not only deformed at the Achilles tendon or the posterior crural musculature. So addressing only that may be hindering their healing as a whole. So they have opted for a full look at the patient from the waist down. Ulcers are a big one. What is the ideal procedure for the ulcer? Are we trying to weaken them intentionally or just temporarily reduce that forefoot pressure? This article out of JBJS showed that 100% of the ulcers healed. It was a relatively small study with an N of 33, but 100 healed, with 75% having less recurrence of the Equinus. But this isn't always a great procedure if the patient has to walk. I know we always jump to TALs if you see a wound, but that Aronow article that I showed earlier does demonstrate that you can get about the same relief from those forefoot pressures as you can with the TAL, with the more proximal.
So I'd like to say a couple of comments about the ulcers, and obviously these are usually common with diabetic patients, and as we know, we have a host of variety of types of diabetic patients. But as we know, diabetes affects the collagen production. It affects the flexibility, the stretchability of the Achilles tendon, and those patients have more tensile resistance. And so, the other thing you have to look at is this diabetic patient a severely neuropathic, apropulsive, sick patient, or are they relatively healthy neuropathic diabetic patient? And I think that would affect your decision on the TAL versus not TAL. Another thing is some of these patients are too sick to even bring to the operating room. So, even doing a TAL in a more sterile environment, you may not have to do this under a general anesthetic. It can be done under a local as long as you have a sterile environment. I think sometimes those things can work really well, or in some cases even the tenotomy. So with all my diabetic patients, I especially look for Equinus And they are less likely to respond to conservative care because of those collagen changes. So I think that's just kind of stratify your diabetics with the apropulsiveness versus a kind of a younger, more active diabetic person who just happens to have neuropathy. So I think that would be a help in your decision-making process.
Have a bunch of tools in your toolkit
Yep.
for all pathologies. So painful plantar fasciitis, it's failed 6 months of care. Ankle Equinus is present. Are you doing just a plantar fasciotomy? Are you doing only a strayer? Are you doing a combination of a plantar fasciotomy and a calf lengthening?
Do you want to know what I'm doing?
I was going to ask. That's all I want to know.
I think when I came out of my program way long ago, we would basically do all plantar fascia resection. And if there's a spur, sometimes we'll remove that. Obviously, we're finding the evolution process is happening. And, the spur is not the problem. So, okay, you just do the fascial release. But I can tell you with firsthand experience that these patients always have lateral overload. They have collapse of the arch, and it does affect their propulsive mechanism of the windlass. And that's important for normal function. So really, I think the better mousetrap is to think global, think big, and address the problem at the gastrocnemius level or higher, and address that at least. And I have found in my experience that has had fantastic results. I can't even tell you, don't recall the last time I've done a fascial release. The only time I ever do fascial releases is if they have excellent range of motion at their ankle, and it's truly a pathologic insertional problem of the fascia. They failed everything else, and many of these people actually have cavus feet. So when I do the lengthening or when I do the resection, actually, you're okay with them losing some of that arch height. And I think that would be the only indication in my hands that a cavus foot type is to do the plantar fascia release on those patients, or even a fasciectomy of some sorts.
So literature would support your decision. The Track Recession was associated with greater post-op improvement than simply doing a plantar fasciotomy. So a patient who is obese presents with a Haglund. There's no tearing of the tendon. There's no intrasubstance pathology, but there's a major Haglund's, or no major Haglund's. Sorry, I misread your question. He failed, I'm going to reread this one. A painful insertion Achilles tendinitis without major tearing and no major Haglund's. So it's simply the insertional Achilles tendinitis with Achilles Equinus, ankle Equinus. Reading's been tough just now.
You want some help?
I really do. This is why I'm doing a fellowship.
So I think this is an interesting question because we all see insertional Achilles tendinitis and sometimes tendinosis, and it's a challenge because obviously the tried and true procedure of detachment and debridement and reattachment, it works well, but it's definitely a long haul for patients. It's not always perfect for every patient, and not every person wants that. It is a lot of downtime. So the concept is is there another option that we have to relieve some of the tension and allow those distal fibers, those collagen fibers, to reorient themselves and heal themselves without going too crazy. So when I do insertional repairs and I'm taking it down and reattaching again, if there's not enough length there, I'll add an augmentation of a gastroc lengthening anyway. So the evolution is, well, what if we started with a stage procedure where we just did that and the patient can walk on it immediately? Perhaps that would be a good option for people. So and I think that there's some interest there. I'm not sure what the literature says. Do you happen to have a slide on the literature in your tool shed there?
Thought you'd never ask. It supports your decision. Again, it's a relatively small study with only 11 patients, but it showed that an isolated lengthening of the gastroc is more simple and more effective than the full reconstruction and takedown of the Haglunds. We have first-hand experience with this. The patient with 10 out of 10 pain, we tried an EGR on her and it was unsuccessful. We did a TAL on her, 10 out of 10 pain at her pre-op, and today was 6 days later and 2 out of 10 pain. It relieved all the tension on that calcaneus and flat foot. So as I mentioned before, with an Equinus contracture or Equinus deformity, you do need some kind of compensation to allow you to walk. So the subtalar joint will pronate, mid-tarsal joint will unlock, and you will get dorsiflexion in the foot, your foot will end up collapsing down on weight bearing though. So I know we had this discussion last night, but what's the appropriate procedure for PTTD? Is it a TAL because it's quick and it will allow you to get to your other more osseous procedures and definitive correction of that flat foot? Is it a Baumann because it's stable and you know you can get the exact correction you want? Do you have an opinion?
Okay, I think this is the most difficult decision-making process, and there's a lot of literature on everything. There's a lot of discussion, and I don't have the perfect answer. But I guess for me, the decision for doing this is multifactorial, as you mentioned earlier. And obviously, if you're doing this for a severely obese person, a lot of stress is going to go through that. And certainly, if you have multiple procedures on the foot, in an older PTD dysfunctional patient that you're reconstructing, sometimes I want permanent weakness of the plantar flexor forces there, especially if I don't get perfect correction in my flat foot correction. So I think for me, I decide what I want to do from a quick procedure standpoint. I also do, if I'm intending on weakening the tendon on purpose so that it can balance out the other structures. And then also, the cosmetics. So if you're doing it in a younger person who's got a flat foot and you want to keep the cosmesis okay, and you're doing, and you want to just get the lengthening there, the Baumann's are really a good option. So, and then the other thing is how much lengthening do you need out of this? There's some variability there, but if it's a severe flat foot, then I'll go with either TAL or Strayer. If it's more mild to moderate, I'll do a little more of a Baumann. But really, it's different for every patient. It's different and each flat foot has its own, each person with flat foot has their own pathology involved. So I think that's the other thing to consider. And that's why there's so much variety. And a lot of work, I think the key is just realizing how much time they're going to have to heal from those types of procedures.
Regardless of the procedure, you choose this as the Baumann that the research was on. It does show that it can effectively correct the tightness of the gastroc with patients with flat foot with no obvious post-op complications. So the literature will agree with that. With a Strayer, I saw Strayers and Baumann's. I didn't see a ton of people doing TALs with their flat feet. So in summary for me, Aquinas is the root of all evil. It's associated with most, if not all, of the podiatric pathology we see, but it's not a one-size-fit-all pathology. There is no great way to choose a perfect procedure, but you have to find the ideal procedure for the ideal patient. So you should be comfortable with a procedure in each zone. You should be comfortable thinking about, I want a stable or I want a selective or less stable, less selective. You want to understand your patient's ideal outcome and their post-op expectations. So if they're an athlete and they want to get on this thing quickly and they want their strength to be the same as it was preoperatively, more proximal. If you're intentionally trying to weaken, you can go more distal. So taking a holistic approach to this seemingly isolated issue is very important. Taking patient risk factors into consideration is important. And again, the patient's expected post-op protocol and what they can do post-operatively is important to take into consideration.
So I guess my 2 cents is that, I think you have to really make a decision on what suits the patients the best. Is this an isolated procedure? And frankly, many times we are doing these isolated because, even if they have metatarsalgia, forefoot problems, we do them with bunions sometimes. But even in an isolated procedure, like we mentioned with the plantar fasciitis, it's pretty effective. I also determine the amount of correction that I need if they're extremely tight, if they're in a negative position or constantly plantar flex. That may play a role into our decision. I also want to know if they're going to have some permanent weakness or short-term weakness. That's important. Or if I need immediate strength, we'll go a little more proximally. And then the other thing is, don't be afraid to stage these patients. Because if you do a proximal Baumann and that's all you do, and it relieves the symptoms and they're getting better, you may not need anything else after that. So that's just something to be aware of. And then this is a little bit of I'll show my slide here. This is a little algorithm that we used here.
It's my lecture in one slide.
It's just kind of a summary. You know, if you have the Bauman is indicated if you want to be able to weight bear these patients right away. So, you know, we walk them even in a sneaker. Lengthening, you get mild to moderate amounts of lengthening, weakness, no immediate weakness, no muscle atrophy, and usually very little cosmetic problems. Strayers, EPFs, you get guarded weight bearing. Lengthening is more moderate, and they can get some short-term weakness, but usually these come back within 3 to 6 months. Obviously, the Vulpius Baker non-weight bearing, because it's a little bit more a lower procedure, you get a little more lengthening and a little bit more short-term weakness. Obviously, the TALs or tenotomies, you should keep these patients off of them unless they're in a crow walker and they're really apropulsive. And then lengthening, you do get a lot, and weakness is a little bit more long-term. So not to read it, but just kind of that's my little overall view that I kind of use.
Yeah, so before this, Dr. Perler asked me what procedure I feel most comfortable with leaving fellowship and doing on my own. I had never done one before fellowship, but the Bauman is actually my answer. I fell in love with that procedure.
Thanks. Yeah, you're welcome. You're welcome. And it turns out pretty good. We're a good team there.
Bunch of cowboys out there.
Yeah. So, yeah, we want to thank you very much. I know your time is valuable, and I hope this was helpful for you all. I know it's a simple concept, but I think it's important to really have it in your head, like your process of determination of where you want to go. There are some variabilities. Hopefully the slides and the information we presented today will let you know that you have data behind you that validates your decision to do these types of procedures. If you don't know how to do this procedure, Josh, how many would you say you've done before it took you really felt comfortable doing these?
The Bauman?
Yeah. 3. So the learning curve is low or quick. And I think it's something that once you get a couple of good techniques, it's really good to have in your tool shed here. So that's it, and I appreciate everybody's time and effort. Does anybody have any questions regarding what we talked about? Any cases that you have had that you were concerned about what decision to make, whatnot?
Andrew, this is Adam. I will say this is pretty cool to see. My second year in Indianapolis, so this would have been 2005. We had our second fellow, and it was Dave Coleman, who is now at University of San Francisco. And at that point, everything I learned was TAL. There were some people doing strayers, but where I came from in Florida and trained, everything was TAL. All the literature said TAL. All the pediatricians did TAL. And that was pretty much what you did. And this fellow came, and he had trained under Shannon Rush on the West Coast, and they were doing the Bauman. And so that was the first time we ever saw it as a program. And he taught one of us, and the next thing you know, we all started doing it. And then, of course, our group in Indianapolis started lecturing about it, and more doctors started to get interested. And I think that our group indirectly was responsible for its spreading on the East Coast, because every single fellow that came through, just like Dr. Stewart said, well, why would I ever do another TAL when I can do the Bauman? Because it's easier, it's less invasive. Well, seemingly less invasive, and there's really no long-term issues with it compared to any of the other ones in terms of weakening. So it's really cool, almost 18 years later, where this has basically become the gold standard. And to the point now where I'll see patients that are still seeing pediatric orthopedic surgeons, and it still blows my mind to this day that a lot of them still favor TALs. And what that represents to us as, podiatrists who mainly see a lot, I mean, we see children, and some of our practices are more focused on that, but the majority of us will see adults. And what we see is an adult that has a really scarified tendinosis from a previous TL that a child had. And it's just very destructive to the tendon. So it's really cool to see the evolution of the Bauman. So it's more of a comment than anything.
No, I think that's a good comment. I would say that, this is not a lecture to say never do a TAL. I mean, I think that it's so popular with pediatrics because, kids heal everything. You lengthen their tendon, they're going to heal it no matter what. It's just going to take a little bit of time for them to get that strength back. Same thing with adults. As we know that when adults rupture their Achilles tendon, it can heal. The concept is, will it heal too long, and will they lose strength? So as long as, if you're doing a TAL, just realize that that's why you're doing it, to get that really excellent range of motion, to purposely, temporarily, or even long-term weaken the tendon. You got to be careful not to over lengthen it. I think one of the questions that came in is, when we do our total ankle replacements, what do we do procedure-wise? Obviously, with those types of procedures, we take our time with our totals. So for us, it's more of a time issue. We want to do something that's a little bit. I purposely want to weaken the Achilles when I do a total. I think it really just helps balance out. So I will do a perc TAL. I have done a gastroc, but very rarely. I think for me, it's more getting that larger increased range of motion and temporarily weakening it, so it puts less stress through the poly, through the anterior portion of the tendon, and that allows the anterior tendons to kind of balance out a little bit better. So you just have to be careful not to over tighten it. And then I think with therapy, they usually come around okay.
It was a more specific question. -5 degrees of dorsiflexion, smallest poly used, posterior capsulotomy was performed, and all soft tissue was released. What do you do? That was kind of my thought process, is start proximal and you can always go further distal. But
So, okay, the question also says, if performing proximal lengthening is still not obtained 90 degrees or enough. Okay, yeah, that's distal. Yeah, so I think for me, that's an excellent kind of question in general, not necessarily just with totals, but there has been the case where I've done a gastroc, we've done three lengthenings and a soleus lengthening, and we still didn't quite get what we were looking for. Now, we did screen for Osteous Aquinas, and it was not there. You have to make sure you double check for that. But what did we do? We didn't get the correction we were looking for. So in that particular patient that I'm remembering, we did a strayer on that patient, and they were able to get the additional length out of it. Certainly, you could come back down to the TAL, but again, the difference is that you will have a little bit more of a permanent weakness, I think, with the TAL. So if you don't be afraid to combine these and help. One other thing I want to mention about the Baumann is that the plantaris tendon can sometimes be right next to your incision, and you might have to lengthen that because that can also restrict some of the dorsiflexion potential. And that if you see that, you may definitely lengthen that as part of that process, because that may be something that's restricting your dorsiflexion ability.
Andrew, I did want to chime in about that, because that was I remember my scrub tech in Indy, she came to all the surgeries with me, and we were with the fellow one time, and I said, it seems like every time we do a Baumann, we get maybe 4 or 5 degrees, and as soon as we release the plantaris, you get your full dorsiflexion. So I said, from now on, like for the next 10, if the plantaris is there, I'm going to release it. And there were 3 specific cases where we released it and we got our 10 degrees of dorsiflexion. I didn't cut the gastroc. And I made that observation to the fellow. The fellow took it back to the group. And actually, just about a year or 2 ago, American Health Network published results on looking at the influence of the plantaris tendon, and basically came to the conclusion that it gives you the most amount of dorsiflexion when you do it by itself, but in conjunction. But just like you said, it's really important when you do the gastroc aponeurosis in your modified fasciotomy to finger sweep up against that medial wall, because you'll find 30% of the time it's not there. But yeah, when you find the plantaris, it's super important to release it. And I would even encourage you, when you open this, before you push between those 2 muscle layers, sweep for the plantaris first, release it because it's a very small release, and see what you get, because you might find those occasional cases where you really don't need to scarify the gastroc. So I thought that was a really interesting find that we had. And like I said, in my 10 cases where I was doing the plantaris release first, I had 3 specific cases where that's all I did, and I got the desired results.
Yeah.
The other thing is I'm kind of on the, and the other fellowship directors, please feel free to chime in, because I think that was a good question about the total ankles. So in the total ankle algorithm for me, I always do the joint replacement, get my final poly, and then I check the calf muscle. And if it's tight, I tend to favor the strayer. But it's just because my emphasis with my total ankles is to get them weight bearing after 2 weeks. And I'm just always hesitant with the TAL to start weight bearing at 2 weeks because I'm just really afraid I'm going to rupture the tendon. So that's not to chime in, or I guess to chime in. That's kind of how I approach it.
Yeah, that's reasonable. Yeah, I think that's a good option for because that's also a relatively quicker procedure, and you're right there. I think that's a good.
And
option.
I do feel the reason why I shy away from the Baumann in my total ankles is the exact point you made. Is the Strayer does give you a lot more lengthening, and it also gives you quite a bit more weakening, which in a total ankle is not a bad thing because you're trying to balance out. You've weakened the anterior group just by your incision and your ankle decompression. So having a well-balanced ankle means somewhat weakening the posterior group. And we know with total ankles, it's all about just achieving a balance and homeostasis from medial to lateral, but also from anterior to posterior. So that was a great question by Dr. Wen.
Yeah, I totally agree with that concept. The other minutia, or if we want to get into the details about the Baumann as well, is do you just release the medial head or the medial side of it? And there's some surgeons that I've talked to who only do the medial side. I typically release the entirety of it. I even use a little METS if it's too far away for me to go further across. The one hard part with the Baumann is if you have a very, very obese person, and those patients, it's really hard to find the tissues and to get down deep especially through that very thick adipose on the medial leg. And so sometimes that may change our influence. And in those patients, frankly, they're very heavy, and a lot of the forces that go through the Achilles tendon and the calf muscle is so severe that you really do want to you do want to weaken them actually. So the weight of the patient is also an influence here as well.
The other thing I was going to bring up is a lot of the research that has been really well presented is by Pat Tahir out of Indianapolis. This has become a big focus of his, and he created a non-surgical gastroc lengthening device. It's just this gradual stretch unit. So I thought that was pretty cool. The other thing, and then I think there's some other really good questions in the queue, but the other thing that I thought was pretty interesting, and dealing with a lot of pediatric orthopedic surgeons, several of them don't actually prefer to do surgery, and instead they go to the medial head and the lateral head, and they pepper it with Botox, and the Botox weakens the muscle, and in return you get some lengthening. And if you think about it, if you weaken the muscle, a lot of times the muscle is fighting you when you go to stretch your fascia, and so they can't, especially with contracture, they can't get the lengthening out of a conservative treatment regimen. So by doing Botox, you're getting a little bit of muscular atrophy. But the most important part of that is not just doing the injection, it's that for the 3 months afterwards, really working on stretching and lengthening. And of course, kids are a little bit more plasticky than adults, and you can achieve a little bit more of that. But I'm kind of curious to see if that's ever going to work its way into our world. I know for me, Botox has worked its way into the treatment of plantar fasciitis. And I think I used to do probably 30 fascial releases a year. And now I'm down to like maybe 1 or 2 because I've gone more towards injection therapy and, just like you said, the gastro pain.
Yeah, but the problem is when you do Botox, I mean, what I've found, especially if you're doing multiple procedures and you're using a sciatic or a popliteal nerve block, they're actually wiping out the muscular component of the effects of the nerve. So almost always after a block, and if I'm doing a multiple stage procedure where we're using peripheral nerve blocks, I'll test it on the table. I won't just jump right to the procedure, because if the muscle is relaxed and you're still doing that and you have Equinus still, I think it's not the muscle spasticity in that case. It's actually true fascial band tightness. And so, I could see it potentially working, but I wouldn't rest all my laurels on the Botox option. Not to say it doesn't have its use, but for me, and when I tell patients and when I'm trying to explain this to them, I think it's easy to talk layperson. I tell them, if you've ever cooked with chicken breast or chicken that has that white shiny covering on it, and I tell them that's the fascia, and that's the part that's tight. So by just cutting that fascia and leaving the muscle alone, the muscle can easily stretch out and move. So for me, that's kind of how I talk to my patients in layperson. That kind of helps them understand what we're doing in there. But I think that I would normally say Botox might work, but for me, I think it's really truly a structural tightness of that situation.
We have two more questions from the chat room. One is Dr. Vora was at, and this is a great question. So when you're doing a bony rigid Aquinas, like a neglected clubfoot, at what point do you think about doing soft tissue work versus potentially doing like a talectomy to get that decompression? And what's your experience with that? Any pearls or pitfalls when it comes to addressing a pure bony Aquinas in a severe deformity, neglected deformity like that?
Well, I don't do a lot of club feet and I don't do a lot of talectomies, but what I do see a lot of is adaptive changes over time in the ankle joint and with the talus and the tibial interaction there. So for me, with those types of patients, especially if they're a little older and they've had the adaptive changes over time, it's not just soft tissue. You have to look at your bone alignment. You have to look at your calcaneal inclination angle. And I think for me, I'm better off getting the foot stable, and then if I need a little bit more dorsiflexion, then if it's at the ankle joint where there's some deformity there, we'll just stage them for a total ankle later with a lengthening if needed. But I don't do a lot of talectomies, and if it's that bad, that deformed, then you just need them plantar grade. Usually we're just doing fusions to get them neutral, especially if it's a diabetic Charcot or something like that.
Take a wedge out.
Two more questions. One is from Dr. Schmidt. She was just saying that she's pretty interested in kind of the success rate of plantar fascial lengthening with cavus, but she wanted to see a little bit more input on isolated gastroc lengthening in regards to insertional Achilles with the cavus feet in the spur, considering the pitch of the calcaneal inclination angle. So what she was saying is, in your post-op regimen, how often are you casting immediately when you do these lengthenings, and what's your regimen for treating these once you've done a lengthening? I think is, and Larissa, please tell me if I'm wrong on that, but what's your post-operative care on these? How are you maintaining the lengthening? How aggressive are you with stretching post-operatively? When do you get them going? Maybe breaking it down by zone.
So I think that as my thinking has evolved and as our experience has evolved, we try to get these patients moving right away. We know that there's a lot of studies on repairing Achilles tendon, and we know that the range of motion of those distal fibers, just even if it's range of motion, increases the better type of collagen that forms at those locations. I mean, there's study after study that shows that. So taking that knowledge that, hey, early range of motion, early movement, but not under huge tension, actually helps that pathologic insertional tendon tissue. So that's my thinking regarding that. So we apply that to the thought of, if I'm going proximal and I know I'm not going to retract and I'm going into Baumann procedure or higher, then I try to walk these patients ASAP. The only restriction would be is if they're having some acute inflammation at the time of their plantar fascia. Actually, what we'll do is we'll combine a gastroc lengthening and a injection of Dex just to kind of calm it down so that they can actually start walking on it. And, we walk them in a boot at first, but we quickly move them. I mean, how quickly are we moving people into sneakers with those types of procedures? First post-op visit, right?
As they can tolerate, yeah.
So, and then we have them start moving it. And because we know we're reducing that tension per square inch on the insertional Achilles significantly. When it comes to strayers, we are a little more careful, but similarly, we get them moving at the very least, and frankly, we keep them in the boot just to prevent them from getting a little too tight again. As far as TALs, usually we keep those patients off of them. But again, your question was regards to the insertional tendonitis. So our experience has been good. It's obviously the only other criteria that I just go right to the insertional repair with the open procedure and everything is if there's physical pain of the bump, and if there's a huge bump that's really truly irritating them back there, and that would be the only thing I wouldn't be able to fix with just the gastroc. And so, interestingly, your question was about calcaneal inclination angle, and I've seen some improvement with that. We get way better improvement with the TAL, obviously, but I've seen some improvement. But I don't really judge that as the end point. I think I judge the solving the pain as the endpoint. So for me, I don't really measure the calc inclination angle afterwards. We observe it, but that's really about it.
Symptomatic relief.
Yeah.
The goal.
I hope that answers your question, Larissa.
A couple other questions that we have. So Dr. Gwynn, Dr. Gwynn was asking about kind of like an MIS Keck and Kelly, or another would be like a closing V osteotomy of the calcaneus to address a posterior insertional Achilles tendonitis. Is that done in isolation, or would you do that in conjunction with some sort of lengthening instead of the traditional, tendo Achilles lift off and grind the bump down and then reattach the Achilles tendon? Do you have any experience with any of those procedures?
I don't do a ton of that. I have done the MIS posterior, superior calcaneal resections, and I've had some mixed results with that. I think they scar down. I think there's some, fasciosis that occurs there from the bone resection. I think if I'm gonna do any bone work in an osteotomy, for me, there's usually insertional pathology there that I am just going to start fresh. I remove all the spurs, start fresh, bone to tendon, cut out. When I do my insertional repairs, I don't just fillet it open and feather the damage out. I actually cut out the damage. So we actually resect a section of the insertion of the Achilles tendon, because that's the pathologic tissue. That's the stuff we want to get rid of. And so then I'll go proximally first to do a lengthening, whether it's a strayer or higher at the Baumann, then insert it distally. And now we've prophylactically lengthened them proximally, and distally we've now have healthy tendon, and we attach that to the healthy bone, gives them the best chance to heal. And I think that works. It destabilizes it a little bit with those medial and lateral deep fascial attachments, but the technology for fixation with tendon to bone is very strong. Pick your company that you use, but it's very strong nowadays. Any comments on that from you? Have you noticed observations about our techniques?
Taking out the pathologic tendon is not something I've done in the past, but I don't know why, because logically it makes all the sense in the world. And I was at first nervous that we cut out too much tendon, but we get enough length with the Baumann or the strayer that it comes down and there's not a ton of tension on the bone, that tendon-bone interface. So yeah, I would agree with that. And I also have not seen the MIS Keck and Kelly, but I feel like if you're doing a closing wedge dorsally, you're kind of functionally flattening the foot. So that doesn't biomechanically make sense to me, but I've not done or seen it, so that's just
you probably
my
won't.
thoughts. Yeah,
I don't like them either.
Plan to. Baumann.
One more question. This came in a little bit earlier. When you're doing kind of this in the Bowman approach, you're going your gastroc, and then you decide that you're going to release the soleus. Are you doing them kind of lined up with each other, or are you staggering them? Like, are you doing one a little bit more proximal, one a little bit more distal, so you don't have adjacent open fascias? I'm guessing from an adhesion purpose.
Yeah, are you asking what actually happens, or are you asking how we do it by the book and how we dictate it in our operating room note?
I think I think like if you do a gastroc.
No, I know what you're asking. I am just kidding. I think that the concept is, yes, we try to stagger it. But if you have a small incision, am I going to make an incision this big just to avoid overlapping my releases? The answer is no. I've not seen adhesions develop postoperatively with, even if you just put them in the same plane, even though that's what all the literature says and everybody talks about, perfect technique. But the reality is, if you lengthen it and you keep them moving, yes, if I put them in a cast afterwards, they're going to adhese down again. So these patients are moving, they're walking right away, they're starting PT very early, and so I mean, it took a while for me to teach all of our fellows, say, hey, push them, push them, push them. And you have to have confidence in these procedures that they can do that. And I think you've picked up on that. And you got to ambulate them, and that's what prevents the adhesions and the adhesive muscle attachments. But it's a huge muscle, and if a small portion in the very, very middle is adhesed, it will work its way out over time with therapy and other types of things. I just haven't had any symptoms with that.
With his technique, when you put that rectal speculum in and angle it further distal or further proximal, intentionally, I guess you're unintentionally staggering them, because you're angling off to the sides, and then when you're doing your soleus, you're kind of in the middle, so you are unintentionally staggering them.
Yeah.
So in the beginning, Dr. Stewart, you had mentioned that the gastric Aquinas is the root of all foot and ankle evils. Dentistry has done a really good job of teaching kids from being very young to brush their teeth 2 minutes twice a day. Don't you think we should have a public health message that if everybody spent 2 minutes twice a day brushing their teeth and stretching their calf muscles, the world would be a much better place? And we might be out of business.
Yeah, that's a good point. If I may just tag team, and I know you asked him a question, but for me, I've actually performed less gastrocnemius lengthenings because I spend so much time with my patients educating them on range of motion, even when their pain goes away. We literally spend a ton of time talking about this. So a lot of times, if you just hand them a sheet, they're not going to do it. I still like the night splints, except I don't do them at night anymore. My suggestion is, and my recommendation, and I forget the article I use this on, is doing it while you're awake for 30 minutes a day per leg, or whichever leg has the Equinus. Supinate the foot a little bit and then pull back on those two straps, and they have to stay awake for 30 minutes a day. And by doing that every day for a month, they get reliably 5 degrees of range of motion. So if you're a non-surgical guy and you're listening to this, just tweak your technique with the night splints. It doesn't work if you sleep with it because people bend their knees, so it doesn't work then. But it does work if you focus them and you educate your patients and have them really do things every day. It can actually work. So I've actually performed less and less gastrocnemius lengthenings or strayers because we spend so much time with that.
Anybody else have any questions?
Wait. I think we both have a question for Dr. Perez. Dr. Perez, are you on, or are you just in the background there?
Oh, I'm casually listening, guys.
Okay. What do you think? What's your take home? You did my fellowship last year. What's your take on this?
I was just wondering why it's taking Josh 2 more minutes than the average.
Well, we all have
you
to
set a
start
high
somewhere.
standard.
Well, 12 minutes, guys. Come on.
That's
no,
right.
In all seriousness, I think it's a great procedure. I've, knock on wood, even out of fellowship, have had very minimal complications and a lot of success, especially with Achilles tendonitis. So, you hit the nail on the head on a lot of that. I was actually going to follow up with a question, but it was so simple compared to Dr. Wynn's question that I was embarrassed to ask. But in practicality, how often are you guys, and maybe Dr. Perler, are you doing these TALs, like the Hoax triple hemisection, in office as opposed to actually taking them to the operating room, maybe for like an isolated, offloading of an ulcer on a diabetic neuropathic patient or something like that?
Yeah, that's a good question. I think in our practice, we have an orthopedic group practice. We don't see quite as many of the really bad train wreck diabetic patients, but I think if you have a patient who is really too sick to go to the hospital and doing these and they're very apropulsive and they have tried a crow walker and they're in a crow walker or in a boot, I think you can do these in the office. If you're willing to do a complete tenotomy on these patients, then a TAL hemisection, I think, is adequate to do in the office. You just have to be very careful to document your sterility and your technique. And sometimes you might have to do this with them on their belly. So you make sure their breathing is adequate enough for that. They're healthy enough for at least that. But yeah, I've done it a handful of times, but not routinely. Usually because there's other issues involved. But Dr. Perler, do you do these in the office?
No, but if Danny does them, I'll send all my patients to him. No, I fortunately, I'm in a similar situation to Andrew. I don't get a lot of the train wreck diabetic patients. There are several people in the community that are really, really good at this, and I would just prefer to get it in their hands. But I do think, to Danny's point, it is a excellent procedure option when you're trying to offload. And I have done some in the hospital or in a surgery center setting when they're sent to me just for that aspect of that wound care. But no, I think it's intriguing, and we're going to see a huge movement. I think Bunyan's kind of started it, and MIS has been around for a long time. I mean, Andrew and I saw it when we were going through our training. I think it's making a pretty big comeback. And not only that, I think that the drills and the understanding and now a lot of the big orthopedic companies are getting involved. So we're going to see a lot of what we do start to work its way towards MIS approach. And I think it's exciting. I don't know, some of these things are hard to do through a minimal incision, but I definitely think that, especially in the Charcot world, the less scar tissue you leave behind and impact you have on the body on the first go round leaves more doors open down the line should you need to do something more advanced. So, I think it is a very good option. It's a great question, Danny.
Great. I agree. I think it's. I think one take-home message that I'll finish with, and then I think we need to wrap it up because it's getting late for everybody. But I really appreciate everybody being here. I think get familiar with this procedure in particular, the Spalman. It's very powerful. You can walk people on it. It's small incision, low risk for infection. It's more proximal in the leg, and it's very, very powerful procedure. And don't neglect it, especially if you're doing other concomitant procedures like bunions, neuromas. I mean, because these patients can still walk on this procedure, and you're doing them a world of help. And if you're not going to do that, then really focus your effort on treating them conservatively from an Equinus standpoint. And I think that way your patients will have overall better satisfaction rates. And don't worry about the economics behind just treating them conservatively either. I think you'll find that patients do come back. They want to get your opinion on how much better they're doing, so that will pay off in dividends. Especially if they've seen 10 other people for plantar fasciitis, nobody gets them better, and you do some stretching exercises with a night splint or something like that, and you can get them better. You're the hero, and you didn't even have to invade their skin. But that's there for if you need it, and if it is, and you get them better, you've avoided having to cause a lot of foot deformity, foot damage. So that's one of my favorite things to do, is because of the negative bad things that happen, or the few bad things that happen, and such an upside positive situation. Yeah.
I should have titled this Aquinas, Why Not the Bauman? But there are other procedures.
Yes.
Yeah. Thank you, everybody.
Yeah. Thank you so much, everybody.
Yeah, it's been an excellent night, and we look to keep building on these. And all the people on the call, it doesn't matter if you're a fellowship director, a fellow, or just an innocent bystander, by all means, chime in on these conversations. It's the reason we called it a roundtable, is we really wanted it to be a roundtable, and you don't even have to bring a cowboy hat to participate.
Excellent.
And I hope everybody has a very good holiday season. Merry Christmas, Happy Hanukkah, and a very great New Year.
I concur. Merry Christmas and Happy New Year, everybody, and Happy Holidays to everybody. Josh, great job.
Thank you, sir. Great leadership.
All right, everybody. Have a good night.